Okay, let's unpack this. We're diving into the hidden world of medical imaging, specifically how doctors manage to make the invisible visible, seeing inside tissues that otherwise all look exactly the same. Our mission today is to thoroughly understand the chemical tools that turn these low-contrast areas into, well, high-contrast diagnostic images, and crucially, what that science demands of us in terms of absolute patient safety.
It really is one of the most critical breakthroughs in diagnostic medicine because, when you simply look at an untreated X-ray, human tissues, muscle, fat, organs, they all have pretty similar densities, similar atomic compositions.
Right, so they just blend together.
Exactly. This means they inherently have incredibly low subject contrast with each other. X-rays pass through relatively uniformly or they get absorbed pretty evenly, and that leaves structures poorly defined.
That basic lack of definition is the core problem, though. We obviously cannot diagnose what we cannot see clearly.
Precisely.
And the solutions aren't chemically simple, are they? We seem to be dealing with two distinct but equally vital categories of tools.
That's right.
On one hand, we have contrast media, which helps visualize anatomic structures, giving us that map of the body. On the other, radiopharmaceuticals, which focus less on the map and more on, say, the traffic moving on the roads, assessing physiological function.
That distinction, structure versus function, is absolutely key. And over the next half hour or so, we'll be synthesizing information on the exact physical mechanics of these agents. We'll trace the chemical revolution that improves safety, detail the serious complications they can carry, and really drill down into the critical importance of a thorough patient history.
Because that history, for the health professional, it's like the essential safety net beneath every single procedure, isn't it?
It truly is. It's paramount.
Okay, let's start with contrast media then. The purpose seems straightforward enough. Visualize anatomic structures, a vessel, a loop of bowel, a kidney, things that you wouldn't normally see clearly on a diagnostic medical image. But if all tissues are relatively transparent to X-rays, how does adding a substance suddenly make one area stand out? Make it opaque?
Yeah, it all comes down to some pretty basic physics and chemistry. Specifically, something called the photoelectric effect is key for contrast visualization.
Okay.
So when X-ray photons strike matter, they can either pass right through or they can be absorbed. Contrast media work by significantly increasing the atomic number, we call it Z, of the specific tissues in the area we're interested in.
And when you dramatically increase that atomic number, Z,
you dramatically increase the likelihood that the tissue will absorb the incoming X-ray photons. That's the photoelectric effect in action. This absorption is absolutely key because it stops the radiation from hitting the detector plate behind the patient. And that creates a high contrast shadow, or lack thereof, on the image.
Is there a simple relationship there between atomic number and absorption?
There is, and it's quite powerful. Mathematically, the chance of the photoelectric effect happening is proportional to the Q of the atomic number. So Z cubed.
Wow, cubed. That's a huge difference.
It is. That cubic relationship means that jumping from the atomic number of, say, oxygen, which is 8 found in soft tissues, to iodine, which is 53, well, that results in an exponential increase in X-ray absorption. That's what makes iodine stand out as bright white on the X-ray image.
Okay, that immediately explains why we're so focused on elements like barium and iodine. We need those chemical heavy hitters to create that contrast effect.
Exactly. Heavy atomic numbers are crucial.
And when we talk about the types of contrast, there seems to be this fundamental sort of binary choice in the imaging world, negative versus positive agent.
Precisely. Let's break that down. Negative agents are what we call radiolucent.
Radiolucent, meaning they let radiation pass through, so they look dark.
Exactly. They appear dark or black on the image. They are composed of low atomic number elements that allow X-rays to pass right through easily.
Like what?
The classic examples are air or gas, like carbon dioxide. Their average atomic number is only around 8. They create contrast not by absorbing X-rays, but by pushing structures aside or outlining the internal surfaces of organs, like the bowel.
Okay, so they provide the outline by being nothing there, essentially.
In a way, yes. They displace the tissue that would normally be there.
But you mentioned a limitation earlier, something about persistence. If negative agents like air are so safe and radiolucent, why aren't they used more? Why can't we just find a way to make them stick around longer?
Well, that low persistence is the major hurdle. They dissipate too quickly, The body absorbs the gas, or it moves along too fast to allow for detailed, timed imaging studies. It just doesn't hang around long enough.
So it's not just persistence, but also the quality of the image. Air doesn't give much structural detail itself.
Right. Air provides minimal structural information on its own. It just provides that negative contrast against the background tissue, or positive contrast agent. So conversely, the positive agents are really the main event for visualizing structure directly.
And these are the ones that are radiopaque.
Correct. They absorb X-rays strongly and appear bright white on the image. And they use those higher atomic number elements we mentioned, like barium Z56 or iodine Z53.
So the lesson here seems pretty simple. If you want things to stand out against the background, you either use the absolute heaviest materials you can, like iodine or barium, or the absolute lightest material, like air or gas. You kind of skip the middle ground elements found in the body.
That's the chemical dichotomy of X-ray visualization, yes. But, contrast goes far beyond standard X-ray now.
Sure.
When we move into other modalities, other ways of imaging, we use highly specialized agents.
Like for ultrasound.
For instance, ultrasound uses microbubbles, tiny gas-filled spheres, to enhance the detection of blood flow. They reflect the sound waves differently.
And for MRI, that's where gadolinium comes in. Right?
Exactly. And critically, for MR scanning, we use gadolinium.
Gadolinium. I know that's often a source of anxiety for patients now, especially those with kidney issues. Can you elaborate a bit on the agent itself and why its use is so highly regulated?
Sure. Gadolinium is a heavy metal element, and as a free ion, just the gadolinium atom on its own, it's highly toxic to the body.
Okay, this sounds bad.
It is. Therefore, it absolutely must be chemically bound or shielded before we can even think about injecting it. We administer it using a special protective chemical cage called a chelating agent. Often it's DTPA, diethylenetriamine, pentacetic acid, or similar complex molecules.
So the protective cage is the key.
This chelated form prevents the toxicity of the free gadolinium ion while still allowing its magnetic properties, which are unique, to enhance the MRI signal. It affects how water molecules behave nearby, which is what MRI detects.
So the actual agent isn't just gadolinium, it's gadolinium plus this protective chemical chaperone molecule.
Exactly right. But, and here's the risk, if the patient has severe renal impairment, if their kidneys aren't working well, they might struggle to excrete this large chelated complex efficiently.
So it hangs around too long.
It can. And in rare, truly tragic cases, particularly in patients with end-stage renal disease, the gadolinium can potentially dechelate. It breaks free from its protective cage inside the body.
And if the toxic free ion gets loose,
it can cause a severe, debilitating, and sometimes fatal condition called nephrogenic systemic fibrosis, or NSF.
that sounds horrific. What exactly is NSF?
NSF involves a painful, progressive hardening and thickening of the skin, muscles, and even internal organs. It can lead to joint contractures, severe immobility, and eventually organ failure. It's devastating.
Wow. Understanding the risk really underscores why assessing renal function, checking how well the kidneys work, is paramount before injecting any heavy metal-based contrast, whether it's iodine for CT or gadolinium for MRI.
Absolutely. It makes you realize that every contrast agent, no matter how effective it is for diagnosis, comes with a trade-off, a potential risk.
It truly makes you wonder what the perfect contrast agent would look like, just in theory. What would science aim for?
The holy grail. The theoretical perfect agent would hit maybe 5 key targets simultaneously.
Okay, what are they?
First, it would provide very high contrast visualization, obviously. Second, it would have extremely low, bordering on zero, toxicity to the patient. Third, it would persist in the patient's anatomy exactly long enough for the imaging to be completed and then disappear.
No lingering.
None. Fourth, it would need to be incredibly low cost and easily accessible globally. And finally, minimal or absolutely no side effects, and crucially, leave absolutely no residual effects within the patient after the procedure.
That's a tall order.
It is. We are always chasing that elusive ideal agent. We've made huge strides, but we're not there yet.
Okay, let's pivot now to one of those heavy hitters.
Yeah.
Barium sulfate, atomic number 56. The absolute workhorse of imaging the GI tract, right?
Absolutely. If you're looking at the esophagus, stomach, small bowel, or colon with x-rays, barium sulfate base 04 is usually involved.
Barium is fascinating because, as you said, it's chemically inert. It doesn't really interact with the body's chemistry in the way iodine does. Yet, it's also one of the most mechanically dangerous substances we administer. That seems like a paradox.
It does, doesn't it? Its physiological inertness is both its strength and its weakness. It passes through the body without being metabolized or absorbed, which is good. But you must remember that clinically, we use it as a suspension.
Not a solution. What's the difference?
It's a key difference. This is not a true solution where particles dissolve completely, like salt in water. It's a non-uniform mixture. You have relatively large molecule-sized particles of barium sulfate that are just held suspended in water, and they have a natural tendency to clump together.
Ah, and that characteristic leads directly to the core challenge of maintaining image quality with barium, right? Something called flocculation.
Absolutely. Flocculation is the enemy of a good barium study. It's the formation of these flaky, clumpy masses when the barium particles precipitate or come out of the suspension.
And if the barium starts clumping together?
It won't evenly coat the mucosal lining the inner surface of the GI tract. The visualization quality drops dramatically. You get gaps, uneven coating, and that can lead to misdiagnoses like small polyps or ulcers. We fight flocculation constantly.
How do you fight it?
Through the use of special stabilizers added to the mixture, sometimes flavors to help with palatability, and really proper, vigorous mixing techniques right before administration.
I found the note on preparation intriguing in the source material. That administration is actually better if mixed with cold tap water. That seems counterintuitive. You'd think warm might be more comfortable for the patient. It almost sounds like adding insult to injury, making them drink cold, chalky stuff.
Yeah, it does seem a bit mean, doesn't it? But there are a couple of good reasons for the cold water. First, sometimes the cold temperature can actually increase patient tolerance slightly, maybe masking that unpleasant chalky taste a tiny bit better.
Okay, marginal benefit there maybe.
Maybe. But second, and this is more important for the technician and the image quality, cold water helps maintain the stability of the suspension. It reduces that natural tendency toward flocculation. It keeps the particles dispersed better for longer.
Ah, okay, so it's a technical requirement for the image.
Pretty much. The ultimate job of the professional administering it is making sure the patient is as comfortable as possible, yes, but also ensuring the material remains properly dispersed until it reaches the target area for imaging.
And then, once the exam is done, what's the single most crucial instruction you need to give the patient?
Without a doubt. They absolutely must be told unequivocally to push fluids following the barium study. Drink lots of water, juice, whatever.
Why is that so critical?
Because barium is inert and it's dense, like chalk dust. As water gets absorbed from the bowel naturally, the barium can harden inside the colon. This can lead to a really severe constipation or impaction, or in the worst case scenario, a complete bowel obstruction, which is a surgical emergency.
Wow. So increased fluid intake helps flush the material out of the GI tract promptly.
Exactly. It keeps things moving. And the professional must also warn the patient, just matter-of-factly, that their stool will probably be white or light-colored for several days.
Good point. That avoids unnecessary panic later.
Absolutely. Just a small detail that prevents a lot of anxiety.
Now, in practice, especially for the colon, we often employ this double contrast technique, using barium, the positive agent, and air, the negative agent, simultaneously.
Yes, the double contrast barium enema, or DCBE. It's a classic technique.
What's the advantage there?
You get the best of both worlds. The barium coats the mucosal lining, showing fine surface details like polyps or inflammation, while the air distends the colon lumen, opening it up so you can see the walls clearly without folds overlapping. That combination can provide really unparalleled detail of the colonic mucosa.
This is where we really transition to the serious complications, isn't it? Because the double contrast technique inherently involves increasing pressure inside the colon with the air or administering large volumes of fluid barium. And that action itself carries significant mechanical risk.
It absolutely does. Administration of barium sulfate, especially under pressure or in large volumes, can lead to very serious complications, including hypervolemia and, quite alarmingly, physical traumas like colon rupture or even vaginal rupture if the enema tip is misplaced.
Okay, colon rupture is obviously a catastrophic emergency, but hypervolemia, that's a subtler fluid-based risk. If barium isn't absorbed into the bloodstream, how does it cause excessive fluid volume, hypervolemia?
That's a really critical point that links barium studies directly to patient fluid management, especially in patients who might already be fragile. To make the barium suspension work, especially for, say, a small bowel follow-through, you often administer quite large volumes of water mixed with the barium.
Okay.
Now, if a patient's bowel function is impaired, maybe they have inflammation or some chronic disease that slows transit, that large volume of water sitting in the bowel for a long time can initiate a significant osmotic shift.
Osmosis again. Water moving across membranes.
Exactly. Water moves rapidly across the semi-permeable membrane of the bowel wall into the bloodstream, trying to dilute the blood relative to the bowel contents. This sudden influx of fluid can overwhelm the circulatory system. That's hypervolemia, dangerous fluid overload.
And that puts huge stress on the heart and lungs.
Huge stress, particularly in elderly patients or those with pre-existing heart failure or kidney problems. It's a real risk with large volume studies.
Which leads us to the absolute number one rule. Barium is strictly, completely contraindicated in suspected cases of bowel perforations. Full stop.
Full stop. It is the absolute gatekeeper rule for barium. If there is any suspicion, any risk at all, that there might be a tear or hole in the bowel wall, you do not use barium.
Why is leakage into the abdomen so much worse with barium compared to, say, an iodinated contrast?
Because barium is inert and particulate. If it leaks into the normally sterile peritoneal cavity, the space around the organs, it acts like a foreign body. It's incredibly difficult, almost impossible to remove surgically or flush out completely.
And it causes inflammation.
It causes a devastating widespread inflammation called chemical peritonitis. It can lead to adhesions, abscesses, sepsis. It's an absolute disaster.
Yeah.
Therefore, any hint of perforation mandates using a water-soluble contrast agent instead, like one based on iodine, which the body can absorb and excrete if it leaks.
Okay, so what specific patient history factors should raise a giant red flag? Factors that increase the risk of perforation and demand the absolute highest level of vigilance before a barium study.
We have to look carefully at factors that might compromise the integrity of the bowel wall tissue. Older age is definitely a factor, partly due to a general loss of tissue tone and elasticity over time, which just makes the colon more fragile, especially when it's distended with air or fluid.
Makes sense. What else?
Patients with known inflammatory bowel conditions like diverticulitis, inflammation of little pouches in the colon wall, or ulcerative colitis, chronic inflammation of the lining. These conditions inherently mean their bowel walls are already inflamed, weakened, or structurally compromised. The risk of perforation during the procedure is significantly higher.
And it's not just diseases, right? The risk extends even to patients on common prescription medications.
It does, and this one is sometimes overlooked. Long-term steroid therapy is a significant risk factor, a relative contraindication for high-pressure studies like a DCBE.
Why steroids?
Because chronic steroid use weakens connective tissues throughout the body, including the bowel wall. It makes it much more susceptible to tearing under the pressure of insufflation or fluid infusion.
That's important to know.
Absolutely. And another hard stop. A lower gastrointestinal series, like a barium enema, is absolutely contraindicated if the patient has undergone a colon biopsy within the previous 2 weeks.
Because the biopsy site is essentially a fresh wound.
Exactly. It's a fresh, weak spot in the tissue integrity. Putting pressure on that area is asking for trouble. You need to wait for it to heal fully.
Okay, those are the risks for the lower GI. What about moving to the upper GI tract, esophagus, stomach? There's the constant threat of aspiration there, isn't there? Getting the barium into the lungs.
Correct. Aspiration is a major concern during upper GI series. We must meticulously assess the patient for that risk beforehand.
What kind of factors increase aspiration risk?
Things that impair swallowing or protective airway reflexes. For example, patients with mental retardation, significant confusion or altered mental status, severe dizziness or dysphagia, or active nausea and vomiting.
If the patient can't cooperate or control their swallowing properly.
The barium can easily go down the wrong pipe into the trachea and lungs. And since barium is inert, heavy, and particulate, it settles deep in the lungs. The body can't easily clear it out like it might clear water.
What does barium do in the lungs?
It causes an immediate and severe chemical pneumonitis inflammation of the lung tissue. Mechanical clearance, like bronchoscopy, is extremely difficult because it's like trying to suction out fine clay. Aspiration of barium often results in severe, potentially life-threatening respiratory complications.
So barium requires incredibly meticulous mechanical risk assessment, just as much as chemical assessment for other agents.
Precisely. It's all about the physical interaction with the body.
Okay, so moving away from the primarily mechanical risks of barium, let's shift gears to the injectable water-soluble powerhouse, iodine. Atomic number 53. This is the basis for most modern systemic contrast media used in CT angiography IVPs.
Yes, iodine is central here. It places us squarely back in that positive radiopaque category, absorbing X-rays strongly because of its high atomic number.
This is the contrast most people listening have probably encountered if they've had a CT scan or an angiogram. But its introduction directly into the bloodstream, intravenously, forced medicine to confront a whole new kind of threat. Not so much a mechanical failure like perforation, but an internal chemical disruption, rooted in solution chemistry, right?
That is the perfect way to put it. And to understand that disruption, we absolutely must talk about osmolality.
Osmolality, okay.
Yeah.
Sounds technical, but you're saying it's critical.
It's not just technical jargon. It's the key metric that really determines patient tolerance and the risk of reaction with iodinated contrast. Osmolality is simply the measure of the total number of particles, could be molecules or ions, dissolved in a solution, specifically per kilogram of water.
Okay, number of particles per kilogram of water.
And here is the crucial insight that completely revolutionized the field of contrast media safety. Most adverse reactions to contrast media result directly from the osmolality of the agent.
Wow, okay. That's a powerful claim. Why does the sheer number of particles matter so intensely once it's inside the body, in the bloodstream?
Because the body's internal chemistry, especially blood plasma, is very carefully balanced around a specific osmolality. When you inject a solution that has an extremely high osmolality, meaning a very high concentration of particles into the bloodstream, you instantly create a massive chemical gradient, a huge imbalance.
And the body tries to fix that imbalance.
Immediately. This gradient initiates osmosis on a large scale. Remember, osmosis is the movement of water across a semi-permeable membrane, like a cell wall or the wall of a blood vessel, moving from an area of low particle concentration to the area of high particle concentration.
Ah, okay. So when this high osmolality contrast hits the bloodstream, it acts like a chemical sponge. It starts aggressively sucking water out of the surrounding tissues and, importantly, out of red blood cells, trying to dilute itself down to equalize the particle concentration with the blood.
Precisely. That rapid, massive water shift causes red blood cells to shrink and deform, which can impede blood flow. It causes blood vessels to dilate suddenly, and it leads directly to the immediate, often uncomfortable symptoms patients experienced frequently with the older contrast agents. That intense feeling of warmth spreading through the body, flushing, sometimes significant pain at the injection site, or even nausea. This high osmolality caused a massive, though usually temporary, physiological disturbance.
Okay, and this fundamental disturbance based on particle count is why we essentially have two distinct eras or types of iodine contrast agents. Let's talk about the old guard first, the ionic contrast agents, also known as HOCM.
Yes, HOCM stands for high osmolarity contrast media. These were the early agents developed, and they were problematic precisely because of how they behaved when mixed with water or injected into blood.
How did they behave?
Chemically, they were salts. And like many salts, when they encountered water, they dissociated. That means they broke apart into charged particles, a positively charged excitation and a negatively charged anion.
So for every single molecule of the contrast agent you injected,
You suddenly got two, or sometimes more, separate osmotically active particles floating around in the solution. This dissociation instantly doubled or even tripled the effective number of particles, spiking the osmolality dramatically. Often these HOCM agents had an osmolality 5, 6, even 7 times higher than that of normal human blood plasma.
wow. So inject one molecule of the old stuff, it immediately explodes into 2 or 3 separate particles, massively increasing the osmotic stress on the body. And that was causing that wave of pain, warmth, and higher reaction rates.
Exactly. More particles meant significantly more osmotic stress, more fluid shifts, more potential for damage at the cellular level, and a demonstrably much higher rate of adverse reactions, both mild and severe.
Okay, then came the chemical revolution, you said, probably starting in the 1980s. This led to non-ionic contrast agents, or LOCM.
Yes, LOCM, standing for lower osmolality contrast media. This was a game changer. The crucial chemical difference is that these agents are designed differently. They're typically larger, more complex molecules, but critically, they do not dissociate into charged particles when mixed with water or injected. They remain as single intact molecules.
Ah, so if you inject one molecule of the new non-ionic stuff, it stays as one single osmotically active particle in the solution. That vastly lowers the total particle count compared to the ion agents, right? And reduces the resulting osmotic shock.
Dramatically reduces it. The osmolality of most LOCM agents is much closer to that of blood plasma, maybe only 2 or 3 times higher, compared to 5 to 7 times for HOCM. This was truly a pure win for patient tolerance and safety.
It sounds like it. It must have been a monumental shift in clinical practice.
It absolutely was. The advantages of non-ionic LOCM agents are overwhelming, which is why they are the standard pretty much everywhere now. First, obviously, they have lower osmolality and are therefore much less toxic at the cellular level because there's minimal ionic breakdown and much less cellular water loss or shrinkage.
Okay, less cellular stress.
Second, they tend to be far more soluble in blood plasma, allowing them to mix more easily and smoothly into the circulation.
And presumably, patients tolerate them much better.
Oh, significantly better. Far fewer of those immediate side effects like warmth and nausea.
Yeah.
And most importantly, they are demonstrably less likely to cause serious patient reactions compared to the old HOCM agents.
But do they still deliver a good image? If they have fewer particles overall, does that affect the contrast quality?
That's a great question. They actually still provide a very high contrast effect. The reason is clever chemistry. These larger non-ionic molecules are designed to carry multiple iodine atoms per molecule. Often 3 or even 6 iodide atoms are packed onto each single non-ionic molecule.
So even though there are fewer molecules overall compared to the dissociated ionic ones, each molecule carries a bigger payload of the heavy iodine atoms needed for X-ray absorption.
Exactly. This dense packing of iodine allows clinicians to achieve the same or even better imaging quality, sometimes even with reduced total injection volumes because the iodine concentration within each molecule is so high.
Very clever. Now, I noticed in the materials that these non-ionic agents, the LOCM, are often warmed before injection. That seemed a bit counterintuitive again. Why warm something that's already safer and more tolerable? Is that truly just for patient comfort, or is there a technical reason? Is it because these larger complex molecules make the liquid thicker, almost syrupy?
You've hit on it exactly. It addresses a critical physical property called viscosity. Because LOCM agents consist of these large, complex, non-ionic molecules, they are inherently quite thick or viscous, especially compared to simple saline solution or the older HOCM agents.
So they don't float as easily.
Right. They are often warmed sometimes up to body temperature specifically to decrease their viscosity. Warming makes the liquid thinner, less resistant to flow.
Why is that important?
It ensures a smoother, safer, and faster injection flow rate. This is especially important when you need to deliver a rapid, high-rate injection, like for CT angiography, where timing is critical to catch the blood vessels full of contrast. It's also crucial when injecting through small-bore catheters or IV lines, as a highly viscous fluid requires much higher pressure, which can be problematic.
So warming is both a patient comfort measure and a crucial technical requirement for consistent, safe delivery of the contrast agent.
Precisely. It ensures the contrast gets where it needs to go when it needs to get there without excessive pressure or flow issues. Okay, so now that we understand the chemistry, especially the importance of osmolality and the benefits of LOCM, we absolutely must focus on the practicalities, safety protocols, and the unfortunate inevitability of adverse reactions.
Right, because even with the much safer non-ionic low osmolality agents, reactions still happen, don't they? They haven't been eliminated entirely.
Not at all. They're significantly reduced compared to the HOCM era, but reactions are still a distinct possibility with any contrast injection. And a key thing to remember is they generally occur very quickly, usually within the first minute or two of the injection starting.
That fast.
Very fast. And they can be entirely unpredictable. A patient might have had contrast before with no issue and react this time, or vice versa. And probably the most crucial point for anyone administering these agents, a mild reaction can worsen and progress to a severe, life-threatening reaction at any time very rapidly. Constant monitoring is essential.
And it's important to distinguish a true reaction from just a side effect, right? Like that warm feeling isn't necessarily a reaction.
Correct. Side effects, like the transient warmth or metallic taste, are expected physiological responses to the injection related to the osmolality and viscosity. An adverse reaction is an unexpected, undesirable, and potentially harmful immune-mediated or physiological response.
Okay. And that monitoring, that vigilance, it really starts not when the needle goes into the vein, but way before that, right? When the patient first walks through the door, by taking that critical patient history.
Absolutely. The history is your first line of defense.
What specific pre-existing conditions does iodine contrast potentially aggravate? Which ones push a patient from a standard risk category into a higher risk one where you need to be extra cautious?
Iodine contrast agents can potentially increase the severity of conditions that already put stress on the body's major systems. This definitely includes sickle cell anemia.
How does contrast affect sickle cell?
The fluid shifts and potential dehydration caused by contrast, even LOCM, can sometimes trigger red blood cells to sickle, leading to a painful vaso-occlusive crisis. So good hydration is extra critical.
Okay, what else?
Pre-existing renal disease is a major one. Impaired kidney function means the contrast isn't cleared from the body efficiently, increasing the risk of contrast-induced nephropathy or kidney injury.
Right, we talk about clearance.
And also diabetes. Diabetes itself is often linked to underlying renal impairment, even if not yet diagnosed, and also to systemic vascular issues. Patients with diabetes, especially long-standing or poorly controlled, are generally considered higher risk.
So knowing about these pre-existing diseases gives the professional the information needed to maybe adjust protocols, ensure extra hydration, or potentially choose a different imaging test if the risk is too high.
Exactly. It allows for risk stratification and mitigation. Increased preparation protocols might be needed.
And renal function seems to be the absolute highest priority check for injectable iodine contrast. Maybe even more so than for gadolinium in many scenarios, simply because the sheer volume of iodine contrast used is often much higher, and the burden of clearance falls squarely on the kidneys.
That's absolutely right. Iodinated contrast media are primarily excreted, almost entirely unchanged, through glomerular filtration in the kidneys. So we must know the status of that filtration system before injecting.
How do we check that?
By monitoring key laboratory values that reflect kidney function. The most common are BUN, blood urea nitrogen, and more importantly, serum creatinine.
And what do high levels of BUN or creatinine tell you?
High levels in the blood plasma indicate that the kidneys are struggling to filter waste products effectively. This means they will also likely struggle to filter out the contrast agent promptly. That increases the contact time of the contrast with the kidney tubules, raising the risk of toxicity and contrast-induced kidney injury.
So checking recent BUN and creatinine levels is standard practice before iodine contrast.
It should be standard practice, yes, especially for patients with known risk factors like age, diabetes, or previous kidney disease. Institutional protocols vary, but it's a key safety check.
And speaking of kidney function and safety checks, there's that really critical drug interaction, that specific medication watch that every professional administering iodine contrast absolutely must know about. Metformin, commonly known by the brand name Glucophage.
Yes. This is non-negotiable professional responsibility. Metformin is a very common drug used to treat type 2 diabetes. The standard guideline, widely accepted, is that metformin should be strictly discontinued for 48 hours before the contrast procedure and withheld for 48 hours after the procedure.
A 4-day total hold.
Yeah.
Why is that interaction so dangerous? Does the contrast interact directly with metformin?
No, it's not a direct drug interaction. The danger lies in a potential sequence of events involving the kidneys. It goes like this. Step 1. The patient receives iodine contrast. Step 2. In a small number of susceptible patients, the contrast agent itself induces some degree of acute kidney injury, impairing kidney function temporarily. Step 3. If the kidneys aren't working well, they fail to clear metformin from the body effectively. Metformin is cleared by the kidneys. Step 4. Metformin levels build up in the bloodstream. Step 5. High levels of metformin can lead to a rare but potentially fatal complication called lactic acidosis.
Lactic acidosis.
Yes, where dangerous levels of lactic acid build up in the bloodstream, leading to severe metabolic problems. It's a medical emergency. So, the 48-hour hold before and after is a precaution to prevent this potential chain reaction by ensuring metformin levels are low if transient kidney injury occurs from the contrast.
That makes perfect sense. A crucial safety protocol based on potential kidney effects.
Absolutely crucial.
Okay, let's structure the adverse reactions themselves now. Because as you said, they can happen, and recognizing the signs and symptoms immediately is critical because it dictates the level of emergency treatment required. The sources break it down into 3 distinct levels: mild, moderate, and severe. Let's start with mild reactions. What falls into that category?
Mild reactions are generally uncomfortable for the patient, but are usually self-limiting. They rarely require specific pharmacological intervention beyond just observation, reassurance, and maybe symptomatic relief, like an anti-nausea medication if needed.
What are the typical signs and symptoms?
Things often confined to local or generalized discomfort. Some nausea, maybe vomiting. That characteristic warm feeling or flushing sensation is very common. Sometimes a mild headache or feeling of dizziness, a strange metallic taste in the mouth, maybe some skin signs like pallor, paleness, or flushing, some chills or sweats.
What about skin reactions like hives?
Yes, limited, scattered urticaria that's hives can be considered mild if it's not widespread or progressing rapidly. Maybe some swelling around the eyes and face, but again, limited. And often just a general feeling of anxiety.
Okay, so mostly unpleasant, but not immediately dangerous.
Yeah.
But you mentioned urticaria, the hives. That seems like the body clearly saying something is wrong here. As the professional, how do you manage the situation and the patient's anxiety when you see even a mild rash appear? You can't just ignore it, right?
Absolutely not. Even if it looks mild, you manage it through calm, constant reassurance, telling the patient what's happening. You monitor their vital signs closely, heart rate, blood pressure, breathing. And crucially, you must be prepared to escalate treatment immediately if it worsens. The distinction between mild and moderate is often that transition from localized, self-limiting issues to signs of systemic threat, particularly to the airway or circulation.
Okay, so what moves a patient definitively into the moderate reaction category? What are those signs of systemic threat?
The moderate reaction category signifies more pronounced systemic issues that absolutely require immediate pharmacological or clinical intervention, but maybe not yet full cardiopulmonary life support.
What are the signs?
We start looking for significant changes in vital signs: tachycardia, a rapid heart rate, or sometimes bradycardia, a slow heart rate. Major shifts in blood pressure, either hypertension, high BP, or hypotension, low BP. The skin reaction might become more pronounced, more widespread, and worsening rapidly.
And respiratory signs are key here.
Absolutely key. This is where airway involvement starts. Signs like dyspnea, subjective feeling of difficulty breathing, objective signs like bronchospasm, which is constriction of the airways causing wheezing that you can hear, and critically, the early stages of laryngeal edema, swelling of the voice box and throat, which might manifest as hoarseness or a tight feeling in the throat.
Any sign of airway compromise like wheezing or laryngeal edema immediately puts it into the moderate category or higher.
Yes. These are red flags indicating the airway is threatened. Rapid treatment is necessary, usually involving things like antihistamines, like Benadryl, possibly corticosteroids, and supplemental oxygen. Close monitoring is vital because moderate can become severe very quickly.
Okay. And finally, the severe reactions. These are the true medical emergencies, right?
Yeah.
Representing a sudden, profound threat to life and requiring immediate advanced life support.
Absolutely. These are rapid, catastrophic failures of the circulatory and/or respiratory system. The symptoms are dramatic and unmistakable.
This is
Profound hypotension, meaning dangerously low blood pressure, leading to shock. Progression to severe laryngeal edema, potentially completely obstructing the airway. Generalized convulsions or seizures. Severe cardiac arrhythmias visible on a monitor. A sudden loss of responsiveness, unresponsiveness, and ultimately, cardiac arrest.
These require immediate activation of emergency protocols, CPR, intubation, emergency medications.
Everything. Full ACLS, advanced cardiac life support protocols. The immediate distinction between these three levels, mild, moderate, severe, must be ingrained in every health professional who works with contrast media, because minutes, or even seconds, in recognizing and responding appropriately can absolutely determine the patient's outcome.
We should also briefly touch on pediatric considerations. A small child system, especially in neonates, is obviously far more sensitive to chemical interventions than in adults. Do the same principles apply?
Yes, the adult principles of contrast administration and reaction management generally apply, but two factors are particularly amplified in neonates and small children.
What are those?
First, contrast osmolality is of even greater importance. Their smaller, more delicate circulatory systems and immature kidneys are more susceptible to the fluid shifts caused by high particle concentrations. Using LOCM is pretty much mandatory.
Makes sense. And the second factor?
Contrast viscosity. Remember we talked about LOCM being thicker? This is a greater concern in kids because their blood vessels and IV catheters have significantly smaller lumens, smaller diameters. A highly viscous agent is harder to push through these tiny vessels safely and at a controlled rate. Warming the contrast might be even more important.
And beyond the physical factors.
Appropriate, empathetic communication with the child is absolutely critical. Explaining things in an age-appropriate way, using distraction techniques. It's crucial for ensuring a safe, calm procedure. Gaining their cooperation directly affects the stability of the injection and the quality of the exam, minimizing motion artifacts.
Ultimately, then, the professional responsibility ties all of this together. It's clearly not just about skillfully performing the injection itself. It's about managing the entire patient care cycle related to the contrast.
It is absolutely the entirety of the process. Contrast agents, it's important to state, must legally be administered only under the direct supervision of a licensed physician who is ultimately responsible. However, the crucial hands-on responsibility often falls to the technologist or nurse performing the injection and monitoring the patient.
And that responsibility includes?
It includes performing that detailed patient assessment and history taking we discussed, providing patient comfort and education before, during, and after, Ensuring those critical post-exam considerations, like the metformin holds and pushing fluids after barium, are clearly communicated and understood.
And above all,
Above all, remaining constantly vigilant during and immediately after the injection to recognize the signs and symptoms of a reaction, classifying its severity accurately and acting appropriately and swiftly according to established protocols, all while maintaining a calm and reassuring presence for the patient, even in an emergency. It's a huge responsibility.
okay, we spent considerable time detailing contrast media, barium and iodine, which fundamentally help us see anatomic structure. Now, let's shift gears completely to that second-grade category of visualization tools you mentioned at the start, the ones that help us look at function. Radiopharmaceuticals.
Yes, and this is where we really need to emphasize that distinction again very clearly. Radiopharmaceuticals are explicitly not contrast agents. They work on entirely different principles.
Okay, not contrast agents. How are they different? What's their goal?
They do not rely on having a high atomic number or using the photoelectric effect to visualize physical structure by absorbing X-rays. Their singular purpose is completely different. It's to assess cellular physiology, metabolism, or perfusion. Basically, how well an organ or tissue is actually working at a cellular level.
Structure versus function again. So if they aren't using heavy elements like iodine or barium to interact with X-rays, what are they actually composed of and how do we see them inside the body?
Good question. They typically consist of two parts joined together. First, a very tiny amount of a radioactive material. We call this the radioisotope or radionuclide. Second, this radioisotope is chemically attached to a specific pharmaceutical molecule that acts as a tracer.
A tracer.
Yes, the pharmaceutical part is chosen because it's known to be taken up, metabolized, or processed by specific cells or systems in the body. It essentially carries the radioisotope along for the ride to the target tissue.
Okay, so the pharmaceutical targets the tissue, bringing the radioactivity with it.
Right.
How is it detected then? No X-rays involved?
Correct. No external X-rays needed. These radioisotopes are chosen because they naturally decay and emit gamma radiation, a form of high-energy photon, as they do so. We don't use X-rays to see them. Instead, the radiopharmaceutical emits the signal from inside the patient.
And we detect that emitted gamma radiation.
Exactly. They are detected by a specialized piece of equipment called a gamma camera, usually found in the nuclear medicine department. The camera picks up the gamma rays coming out of the patient and creates an image showing where the radiopharmaceutical has accumulated.
So the functional pathway, how the body handles that pharmaceutical component, is absolutely critical. The chemistry has to be perfect for the tracer to target the right cells or processes. This brings us to a key concept mentioned in the sources. Biodistribution. What does that mean?
Biodistribution is essentially the roadmap of the radiopharmaceutical within the body. It describes how the radioactive tracer travels through the bloodstream, how it concentrates in specific organs or tissues, the target, and how it's metabolized or cleared from the body over time. Understanding the expected biodistribution of a specific agent is crucial for interpreting the images correctly.
So if you want to see bone activity, you need a pharmaceutical part that naturally goes to bone.
Precisely. If we want to see areas of high bone turnover, perhaps looking for cancer spread, metastases, or subtle fractures, we use a radiopharmaceutical like 99-milli-Tc medronate. The medronate part is a phosphonate compound that naturally integrates into the bone matrix, especially where active bone remodeling is occurring. The technetium 99-metarid 99-milli-Tc attached provides the gamma signal.
Okay, so bright spots on a bone scan show areas of high metabolic activity.
Exactly. It's showing function, not just structure.
Can you give us a few more examples? How do we target function in other organs, like the kidneys?
Sure. For assessing kidney function, looking at things like how well each kidney is filtering blood, measuring clearance rates, checking for obstructions or poor perfusion, we might use 99-milli-Tc merciatide. This agent is actively secreted by the kidney tubules, so we can watch it being taken up and cleared over time.
What about the heart?
Very important application in cardiovascular studies to assess myocardial perfusion, meaning how well blood is actually reaching the heart muscle itself. Especially under stress, we inject agents like 99-milli-Tc tetraphosmin or perhaps 2011-1-TL thallus chloride volume.
And how does that show function?
These agents are distributed to the heart muscle cells in proportion to blood flow. If an area of the heart muscle isn't receiving enough blood, perhaps due to a blocked coronary artery, that area simply won't take up the tracer as much. It will appear as a cold spot or defect on the images, indicating a functional problem, ischemia, or infarction.
Fascinating. And I read that some radiopharmaceuticals can be used both for diagnostic imaging and for therapy. That seems incredibly powerful.
It is. The best example is probably 131I sodium iodide for the thyroid gland.
How does that work?
The body naturally uses iodine to make thyroid hormones. The thyroid gland actively traps iodine from the bloodstream. When we administer radioactive iodine 131I, as sodium iodide, it gets trapped by thyroid cells just like regular iodine.
So you can image the thyroid gland.
Yes, with a low dose, we can image the gland's structure and function, see if it's overactive, underactive, has nodules. But iodine 131 emits not just gamma rays for imaging, but also beta particles, which deposit their energy locally. So if we give a much higher therapeutic dose.
The trapped radioactivity destroys the thyroid cells.
Exactly. The intense local radiation can be used for therapy or ablation, destroying overactive thyroid tissue, like in Graves' disease, or killing remaining cancerous thyroid tissue after surgery, while minimizing radiation exposure to the rest of the body because it concentrates so specifically. It's a prime example of theranostics using the same agent for diagnosis and therapy.
That's amazing.
Yeah.
Are there others? Maybe for infection?
Yes, we can even use agents like 67Ga citrate, gallium citrate. Gallium behaves similarly to iron in the body and tends to accumulate in areas of inflammation and infection where white blood cells gather and protein binding increases. So it helps us pinpoint hidden infections or inflammation. Again, assessing a physiological process.
Now, because these materials are radioactive, they obviously present unique handling challenges that are completely separate from the chemical or osmotic risks we talked about with barium or iodine contrast. Safety takes on a different dimension.
Absolutely. The procedures and precautions in a nuclear medicine department, often called the hot lab, are very stringent and different from standard radiology.
What's the primary challenge?
The primary and most intense, unavoidable challenge is that time is of the essence because of radioactive decay. These radioisotopes are constantly losing their radioactivity according to their specific half-life.
Can you give an example?
Sure. Technetium 99 m 99 milli-Tc, which is the workhorse, most commonly used tracer for many scans, has a physical half-life of just 6.02 hours.
Only 6 hours.
Yes. That means its radioactivity drops by half every 6 hours. So a dose prepared in the morning will be significantly less potent by the afternoon. This demands incredibly precise logistics and scheduling. Doses are often prepared patient-specific just before injection. Inventory has to be managed literally by the clock. You have to minimize waste because you can't just store unused doses for days or weeks like you can with regular drugs or contrast media.
So, short half-lives are good for minimizing patient radiation dose, but a nightmare for logistics. What about longer-lived isotopes like the iodine 131 used for therapy?
Iodine 131 has a half-life of 8.02 days. That's more manageable logistically, but it also means the patient remains radioactive for longer, requiring specific radiation safety precautions after therapy, like temporary isolation or limiting close contact with others, especially children and pregnant women.
Okay, so time is critical. What else are the major safety concerns in handling these?
Contamination and spillage are of paramount importance. Because these agents are actively emitting radiation, any contamination, whether it's external, like a spill on a countertop or gloves, or internal, like accidentally injecting some outside the vein, infiltration, is a major issue.
Why? Does it just affect the image?
It definitely affects the image. Spills or infiltrations create hotspots or artifacts on the gamma camera images, potentially obscuring the actual diagnostic information or mimicking disease. It can ruin the study.
But it's more than just image quality, right?
Yeah. Oh, absolutely. More importantly, contamination unnecessarily increases the radiation exposure, the dose, to both the patient and to the healthcare personnel working in the area. We are legally and ethically bound by the LRR principle, as low as reasonably achievable, to minimize radiation dose at all times, so preventing contamination through meticulous technique is crucial.
So safe, rapid, and incredibly precise handling is really the core skill set in nuclear medicine technology.
It truly is. Dealing with unsealed radioactive sources requires constant vigilance and adherence to strict safety protocols. #tag outro.
So let's try to wrap this up. What does this all mean? We started today with that basic problem of low subject contrast in the human body, how everything looks kind of gray and similar on a standard X-ray. And we saw how contrast media, primarily barium and iodine, are really indispensable tools. They allow us to visualize anatomic structure directly based on those extent differences in atomic number, relying fundamentally on the physics of the photoelectric effect.
And we traced that crucial revolution in iodine chemistry, The shift from the old high osmolality ionic agents to the much safer non-ionic low osmolality agents, LOCM, that shift dramatically improved patient safety by minimizing the osmotic shock and cellular toxicity.
Right, a huge step forward. Though, as we stressed, the risk of adverse reactions, sometimes severe and unpredictable, remains a reality that demands constant vigilance from the professional.
Absolutely. Vigilance and preparedness are key.
And then we've made that clear functional distinction. Contrast media are primarily for visualizing anatomic structure, requiring careful mechanical risk assessment for barium and chemical osmotic risk assessment for iodine.
Whereas radiopharmaceuticals, detected by a gamma camera, are used strictly for assessing cellular physiology and perfusion, how things are working, demanding absolute precision and handling due to radioactive decay and contamination risks. Two different tools for two different jobs.
But the common thread, the constant across both of these incredibly powerful visualization modalities, is that unwavering professional responsibility.
Yes. That responsibility encompasses detailed patient assessment, anticipating risk factors like kidney function or drug interactions like metformin, potentially leading to lactic acidosis, ensuring patient comfort and understanding, and critically, the immediate recognition of adverse reaction symptoms to initiate the required level of treatment swiftly and calmly. It's a non-negotiable obligation.
So this brings us to a final thought, a question perhaps for you, the learner, to consider as you rank up this deep dive with us. Given the inherent complexities, the costs, and the undeniable, though hopefully small, patient risks associated with administering any of these chemical or radioactive agents, both barium and iodine contrast, and radiopharmaceuticals, how might advancing technology continue to change the game?
That's the big question looking forward. Think about things like much more powerful computational analysis AI, perhaps, that could potentially infer tissue density or function directly from subtle signals in unenhanced images without needing chemical help. Or maybe completely non-chemical, non-radioactive imaging modalities we haven't fully developed yet. How will these advancements continue to reduce our dependency on needing any physical contrast intervention in the next decade?
The pursuit of that perfect, completely risk-free diagnostic picture.
Oh,
It definitely continues in labs and clinics all around the world.
it certainly does.